Hello, my name is Isaac, and I'm a final year medical student at Swansea University, and this is Up to F1 Speed, a new podcast for medical students. This podcast is aimed at medical students who are intending to work in the British healthcare system upon graduation. These podcasts may be of use to others, but keep in mind that they are specifically aimed at British medical students, and so may be of less use for you if you are not a UK-based medical student. These podcasts will address common medical and surgical emergencies you may be expected to encounter and manage as an F1 or a house officer. I decided to address these topics in particular, as when I've spoken to other students in my year, it is this kind of thing that they are most concerned about dealing with once we begin work. These are topics that you should have covered as part of your medical school training, and therefore I want to keep these relatively short and concise, so I won't be delving too deeply into the intricate physiology and biochemistry of each situation, but this might be touched upon where it is particularly relevant. Overall, the aim is that these should be a casual resource that we can use for revision and to adequately prepare you to handle situations competently and effectively for when you begin work as a junior doctor. Before we begin, I'll quickly go over the basic structure this podcast will follow. I will open with some basic questions as a way of introducing the topic and also so that you can assess your own level of knowledge before we dive in. Then I'll move on to the basic teaching on the topic, which, as I said before, I'll try to keep concise and relevant. And after that, there'll be some more questions on the information that was covered. Hopefully this time you should see some improvement from the opening questions. Hopefully you'll be more comfortable and confident answering the questions, and hopefully this should show some progress from before you listen to the podcast. After that, I'll wrap up and talk about some of the feedback I'd like from any listeners of the podcast if you're willing and able to spare the time. With that said, let's get started. This first episode will focus on the topic of acute MI. It seems like an obvious place to start. It's typically one of the first things people think about when they think about acute medicine, and it's for good reason. It's a very common occurrence. According to the British Heart Foundation, there are around 200,000 hospital admissions each year in the UK due to heart attack, and additionally, early and appropriate management has a profound effect. In the 1960s, 7 out of 10 heart attacks in the UK were fatal. These days, around 7 out of 10 people will survive. So it's important we're able to recognise and manage these patients so we can keep that trend going. So we'll start off with a few questions just so we can introduce the topic and you can get a handle on your own level of knowledge regarding the topic. So question 1. Which of the following is a common risk factor for a painless or silent MI? So a risk factor for painless or silent MI. A. An extensive smoking history. B. Age of less than 50. C. A history of diabetes. D. A history of familial hyperlipidemia. So I'll go through those again. A. An extensive smoking history. B. An age of less than 50. C. A history of diabetes. Or D. Familial hyperlipidemia. Question 2. Which of these is not an important differential to consider when assessing a patient complaining of central chest pain? So not an important differential for a patient presenting with central chest pain. So A. Aortic dissection. B. Appendicitis. C. Pneumonia. Or D. Acute cholecystitis. So I'll go through those again. A. Aortic dissection. B. Appendicitis. C. Pneumonia. Or D. Acute cholecystitis. And finally, which of these is the appropriate initial dose of aspirin for a patient you suspect to be experiencing an acute MI? So the initial dose of aspirin for a patient you are treating for acute MI. So A. 75 milligrams. B. 150 milligrams. C. 300 milligrams. Or D. 600 milligrams. I'll go through those again. A. 75 milligrams. B. 150. C. 300. Or D. 600 milligrams. So hopefully you've had a think about those. We'll go through the answers now. So question 1 is which was the following is a common risk factor for painless or silent MI? And the correct answer for that was a history of diabetes. I'll just quickly go through the other options. So an extensive smoking history would be a risk factor for MI, but not in particular a painless or a silent MI. An age of less than 50, younger people are less likely to have an MI in general. C, which was diabetes, which was the correct answer, is a known risk factor for silent MI. And then D, familial hyperlipidemia, which is a risk factor for regular MI, but not for silent MI in particular. The second question is which of these is not an important differential to consider when assessing a patient complaining of central chest pain? So which one's not an important differential? The options were A, aortic dissection, which absolutely is. It's a very important differential. B was appendicitis, which is the correct answer. Appendicitis is very unlikely to cause central chest pain. C is pneumonia, which, whilst not classically causing central chest pain, it can do, so it's important to consider. And D, acute cholecystitis, same as pneumonia. It's not classically doesn't classically produce central chest pain, but it can, so it's important to consider. And then finally, which is the appropriate initial dose of aspirin for a patient you suspect to be experiencing an acute MI? So aspirin for acute MI options were A, 75 milligrams, which is incorrect. That's the dose you give people after an MI or prophylactically to prevent an MI or a stroke. B is 150 milligrams, which is incorrect. C, which is 300 milligrams, which is the correct answer. So that's what you give for a patient experiencing an acute MI. And then D, 600 milligrams, which is incorrect. So hopefully you did okay, and hopefully that introduces the questions. And then we'll move on to actually teaching the topic now. Okay, so I'm going to move on to the actual teaching of the topic now. I'm going to start off with a brief introduction to what acute coronary syndrome, or MI, is. So acute coronary syndrome is a spectrum of disease ranging from unstable angina all the way to evolving myocardial infarction, which is what this episode of the podcast is going to focus on. The basic underlying physiology is a reduction or a cessation of blood flow through one or more of the coronary arteries that supply the myocardium. This will result in insufficient O2 delivery to the myocardium, which will cause pain, classically what you experience in angina, and in full-blown MI you'll get myocardial necrosis or cell death in the heart. Typically this is caused by a thrombus or clot in the artery, but much less commonly it can also be caused by rate disturbance or blood pressure disturbances reducing blood flow. You're very likely to encounter a patient suffering from this at some point during your junior years, well, several times in fact. You'll encounter it all the time, whether that's an inpatient on the wards or if you're doing an A&E job, so you'll see this constantly. So as mentioned previously, it's very important that you know how to recognise it and how to manage it. So we'll go on to the classical presenting complaint of a patient suffering from an MI. So typically what you think of is central chest pain of recent onset, and people describe this as being a heavy weight on the chest or a crushing weight on the chest. That's the typical description, and you often think about it radiating to the left shoulder and the jaw. But sometimes it can also be the right shoulder, which is something I've seen well on placement on A&E in the past. So don't fixate on it radiating to the left shoulder. Pretty much every single patient you see will be breathless unless they're very, very ill. Some will have nausea and vomiting, and often they're very unwell, which is what this podcast is going to lean towards, the very unwell patients. So they'll be grey, clammy, sweaty. Sometimes they'll collapse. Sometimes there'll be a reduced conscious level. Something else to be aware of, something that we mentioned in the questions before, is that often patients will come in without pain and only present with something simple like breathlessness. So this is particularly common in older patients and diabetics. So it's something you should really be aware of, because obviously elderly patients and diabetics make up a huge portion of the patients you'll see. So sometimes they'll come in no pain at all, just breathlessness. So keep that in the back of your mind. Also, there's many other conditions that can also present with chest pain, and also with the other symptoms that we've talked about. It's important you keep an open mind to differentials. Don't fixate or tunnel vision on MI. Some of the most important ones to consider include anxiety, musculoskeletal pain, pneumothorax, esophagitis, pneumonia, pulmonary embolism, aortic dissection, cholecystitis. It's quite an extensive list. There's more, and some of these are quite serious, so don't just fixate on MI. Have those in the back of your mind as well, and I'd recommend you go over those because there's more that I can talk about in this podcast. So I thought we'd talk a little about how to approach these patients. So as an F1, you'll see these patients either as an A&E job, or depending on which health board you're in, or on the ward. And as with any acutely unwell patient, it's best to approach these patients with the classic systematic ABC approach that you should be familiar with, that you should have gone through as part of your medical training. And I'll go through the specific steps involved in that in a moment. But first, I thought we'd go over a particular scenario that you may find yourself in that become quite uncomfortable, especially when you first start your junior jobs. So you might find yourself in a position where you're on call and you're bleeped to see a patient who's unwell with chest pain. And there's a few things you can ask the ward staff to do for you before you arrive to see the patient. I've got this list of things from the MDU's hands-on guide to the foundation program, which is a really helpful book. It's something I've picked up, and there's loads of little advice like this for when you're doing your foundation job, so it's something I'd recommend, and it's something I thought I'd share that was relevant to the topic. So things you can do, ask the ward staff to do before you arrive to see the patient. So ask them to perform an ECG, ask them to do a repeat of the basic OBS, and then give the patient GTN if they have a history of ischemic heart disease. This should just give you a head start before you actually go to see the patient yourself, so when you go there you're ready to do what you need to do. And another final point before we move on to the ABC and management If you do go to see a patient who's very ill or you feel like you're in over your head, don't be hesitant to ask for help from an experienced colleague. And if you believe the patient to be peri-arrest, consider putting a crash call there and then. This applies to all acute scenarios, not just MI. Okay, so now I thought we'd go over the ABC approach to a patient you think who's coming with chest pain or you suspect is suffering from an MI. So it's the same as anything else. You start off with airway, that's A, which is often very easy to assess. If the patient is able to talk normally, it's secure and it's safe to move on to B. However, if there are secretions or the patient's mumbling, gurgling or snoring, or if you detect any reduced conscious level, then the patient's airway may be compromised and you need to consider airway support. I'm not going to go into the details of each little thing because this is focusing on MI, but if you are interested, then the best resource I can find online is OSCE Stop, and there'll be a link to that in the show notes or in the description, depending on how you're listening to this podcast. So anyway, next stage is breathing. So you're going to want to be getting some pulse oximetry on, which is O2 sats, which in MI can be reduced, particularly if they're very unwell. You want to measure their respiratory rate, which will be raised in almost all patients with MI, except if they're incredibly ill. You'll want to do an abbreviated chest exam, so you want to look for cyanosis. They can be cyanosed in MI, tracheal deviation, chest expansion, percussion and auscultation. These are mostly relevant for chest pain differentials, such as PE or pneumothorax. So if you're slightly confused about maybe the origin of the chest pain, you're not sure if it's MI, this will rule out any other things. And then you might want to look at the patient's calves, which is useful if you're suspecting PE, which could be caused by a DVT in the legs. So once you've done breathing, you need to address any issues that you've discovered. Typically in an MI, you'll probably want to be giving this patient oxygen, but then you can move on to circulation. So next things you want to assess in circulation, you want to test the patient's blood pressure, which in an MI can be high, low or unchanged depending on a lot of factors that are beyond the scope of this podcast, so I'm not going to go into those. But one thing to be aware of is that there's often a narrow pulse pressure due to impaired myocardial function. Then you want to do an ECG. There are loads of important ECG changes associated with an MI that are important to be aware of. Classically, you get the ST elevation in the affected territories, but also you can have non-STEMIs or non-ST elevation, which is also an MI, or new onset left bundle branch block, which can be a sign of an MI, and that's too broad of a subject to keep this podcast concise. So I recommend reading around the topic when you have an opportunity. Some of the best resources I found for that are Life in the Fast Lane and the Oxford Handbook of Emergency Medicine have really good summaries of this kind of thing, and that's really important to be aware of. So anyway, measuring circulation. So heart rate, that can be raised or it can be reduced depending on a lot of factors. You want to measure capillary refill. You want to auscultate the heart, which in MI it might be unaffected, or you might have things like a quiet first heart sound or a third heart sound, which is quite complicated, so I won't go into them either. And basically you're going to be wanting to put in cannulas in pretty much every patient you suspect of having an MI. So you'll put in a couple of large bore cannulas bilaterally, and you want to take some blood of those. So important bloods to take from a patient you suspect with chest pain. So for full blood counts, urea and electrolyte, blood glucose, lipids, and of course these are really important ones, cardiac enzymes, so that's TROP-T or I, and creatine kinase. They're really important for so when you suspect with an MI, and then also a blood gas, ideally an ABG, but a VBG can be useful as well. So moving on from C, then there's D, so this is disability. You'll want to measure glucose, temperature, their conscious level, either GCS or AVPU, depending on which one you're most comfortable with, and then pupils, and these are mainly for differentials as well. And then also, finally E, so exposure. So look for any rashes, injuries or bleeding, and that's also mainly for differentials, less relevant for MI. So just a note about the ABC approach. Only move on to the next letter when the current letter has been appropriately assessed and treated. Keep reassessing if you find yourself lost, and that's true of any ABC assessment, not just an MI or a chest pain. Okay, so we're going to move on from the ABC assessment, and now we're going to move on to treatment. So hopefully from your patient's signs and symptoms and also your structured assessment, in this scenario you've been able to accurately diagnose that your patient is suffering from an MI whilst also excluding any likely differentials. That's the dream scenario. The aim of this section is to cover how you should be treating these patients. So fortunately the initial treatment for an MI or what's suspected of an F1 can be summarised with a well-known and easy to remember mnemonic that you've probably heard of before, and that is MONAC, so MONAC. So MONAC. So the M stands for morphine. So you want to give these patients, they will be in a lot of pain and they need significant pain management to treat that. So you want to be giving them IV more, 10 milligrams in 10 mils, and you want to titrate that up to appropriate pain management. So the next is O, so that stands for oxygen. So you want to be giving these patients high flow oxygen, 15 litres, and you want to aim for SATs of between 94 and 98%, unless there's another reason not to, because of COPD or something like that. The next letter is N, so that stands for nitrates. So if they've got a GTN spray, then you'll be giving them 2 puffs of the GTN spray. If they're not hypertensive, if they are hypertensive, then that's contraindicated. And if that's ineffective, then you might move on to IV nitrates, but that's beyond the scope of this podcast. The next letter after N is A, and that stands for aspirin, so an antiplatelet. So that's to reduce the impact of the MI actually on the damage it would do. And you'll be giving them 300 milligrams oral in the acute scenario, and then there's different doses later on for like ongoing treatment, but we're going to be focusing on the acute scenario. So that's 300 milligrams oral. And then finally C stands for clopidogrel, which is another antiplatelet, does the same job as aspirin, it's just an additive effect, and that's also 300 milligrams, and then there's long-term dosing that I won't go into. So let's go through that again. So MONAC. So M is morphine for pain management, titrate up to appropriate pain management. O stands for oxygen, aim for SATs of 94 to 98%, unless there's another reason not to, such as COPD. Nitrates, 2 puffs of GTN spray if not hypertensive. A for aspirin, 300 milligrams oral. C is clopidogrel, 300 milligrams oral as well. So that's a simplified treatment, MONAC, easy to remember. And at this point, once all of this is in place, you should be contacting cardiology to come and assess the patient, as they'll need further specialist treatment, which will need to be assessed by a cardiologist. That should probably be something like PCI or maybe surgery. However, that is beyond the level of an F1, and therefore it won't be covered in this podcast. Okay, so that's the teaching done. So let's move on to some questions just to assess your knowledge. Hopefully you've learned something from this podcast. Hopefully you should be more confident answering these than the questions that we asked at the start of the podcast. So first question, question 1. Which of the following is an appropriate target oxygen saturation when administering oxygen to a patient suffering from an acute MI who has no other known comorbidities? Which is unlikely with a patient with an MI, but there we are. That's just to keep the question simple. So an appropriate target oxygen saturation when giving oxygen to a patient suffering from acute MI. A, 94 to 98%. B, 100%. C, 88 to 92%. Or D, 50%. So I'll go over those again. A, 94 to 98%. B, 100%. C, 88 to 92%. Or D, 50%. Okay, next question. Question 2. What does the N stand for in the MONAC mnemonic? A, naloxone. B, nasopharyngeal. C, neurological assessment. Or D, nitrates. So we'll go over that again. What does the N stand for in the MONAC mnemonic? A, naloxone. B, nasopharyngeal. C, neurological assessment. Or D, nitrates. Okay, and the third and final question. What is the appropriate initial dose of clopidogrel for a patient you suspect to be experiencing an acute MI? So that's clopidogrel for acute MI. What's the dose? The options are A, 75 milligrams, B, 150 milligrams, C, 300 milligrams, or D, 600 milligrams. So hopefully you've had a chance to think about those questions, and we'll go over the answers, and also I'll go over the wrong answers as well and explain why they're wrong. So the first question was the appropriate target oxygen saturation when administering oxygen to a patient suffering from acute MI. So option A was 94 to 98%. This is the correct answer. That's what you should be going for. That's a reasonable level, and it will provide good oxygen saturation. B, 100%, which whilst it sounds good or sounds desirable, it may not be realistic, and it's not necessary to be that high. And in fact, there are some drawbacks to having an O2 saturation of that high, so we won't be aiming for that. C is 88 to 92%, which is low for a patient with no other known comorbidities, but this is what you should be aiming for with a patient with COPD. And D is 50%, which is way too low. That's dangerous. The second question, what does the N stand for in the MONAC mnemonic? Option A was naloxone, which is, of course, not related to MI. That's the antidote for opiate overdose. B, nasopharyngeal. That's irrelevant. That's something else completely. C, neurological assessment, which is not something you'd be doing in an acute MI scenario. And D was nitrates, which is the correct answer. That's either GTN spray or IV nitrates. And question 3, the final question, what is the appropriate dose of clopidogrel in acute MI? So option A was 75 milligrams, which whilst is the dose you will be using. That's for long-term management, not for an acute scenario. B is 150 milligrams, which is incorrect. C is 300 milligrams, which is correct. That's the dose you should be using, just like aspirin, 300 milligrams. And D, 600 milligrams, which is too high. That's not what you're aiming for. Okay, so that's the end of the podcast. Thank you very much for listening, and I hope you found it useful. Hopefully you enjoyed it enough that you'll listen to the second episode of this series, which will cover acute asthma, another very big topic in acute medicine. And whether you like the episode or not, these initial 2 episodes are part of a university project that I am completing, so I'd very much appreciate any feedback you have for me regarding this episode, as well as the series as a whole. If you would like to provide formal feedback, I'll provide a link to a questionnaire I've produced in the show notes or the video description, depending on the format you are consuming this. And if you could take the time to fill this in, I'll be really grateful. It's really helpful for me. If you'd like to provide more informal feedback, you can do that either by commenting on the comment section if you're listening via YouTube, and I'm not entirely sure about iTunes. I'm trying to sort that out at the minute, but we'll keep you posted on that. Or you can contact me directly via the show's Twitter page, which is at up to F1 Speedcast, and the 1 in F1 is the number 1. Or you can email me at upto f1speed@gmail.com, and once again the 1 is the number 1, so that's at up to F1 Speedcast for Twitter and upto f1speed@gmail.com for the email. I'd particularly like to hear what you liked or disliked about the podcast, anything you found particularly useful, or anything you thought was not helpful, any ways you feel I can improve the podcast, anything I can add or change, and also any tips you can share with other listeners in regards to the topic of the podcast. So any tips you have about managing acute MI, how you do it, or anything you think I missed that was important. Anyway, that's it. Hopefully I'll see you in the next episode. Thanks for listening, and bye.